This video is on nephron pharmacology. So pharmacology and drugs that work on the nephron. And anytime I talk about pharmacology, I like to draw the normal pathway out first, and that way we can see how and where the drug manipulates the normal pathway. So let's just draw the normal nephron first. You got your Bowman's capsule, your proximal convoluted tubule, you got your thin descending limb, your thick ascending limb, your distal convoluted tubule, and your collecting duct, right? Now what does your proximal convoluted tubule do? Wasn't that your workhorse? Didn't it do most of the things? So reabsorbed amino acids, reabsorbed glucose, reabsorbed most of the sodium. Do you remember how it reabsorbed sodium? It had that nice sodium hydrogen pump, right? Here's your cell. It'll reabsorb sodium, and pump out hydrogen in return, hydrogen. And that hydrogen will combine with bicarb, HCO3, become carbonic acid, H2CO3, and then an enzyme called carbonic anhydrase would turn it back to H2O and CO2. And that go in your cell, and carbonic anhydrase again would basically do the reverse of this. So break it back down to bicarb and acid. That bicarb will be reabsorbed, and that acid we just pump back out, do the whole cycle again. That was your PCT. How about your thin descending limb? Your thin descending limb was, we said, absorb water, but it was impermeable to salts, to salt. Your thick was kind of the opposite. Your thick ascending limb was impermeable to water, but it loved salts, and had that huge ion channel, the sodium, potassium, chloride channel. All right, so it loved to reabsorb all these salts. And we said potassium didn't really follow the rules. Sometimes it leaked back, made a positive lumen, and that positive lumen pushed other positive ions away from it, like calcium, like magnesium. So this is also the place where you reabsorb a lot of calcium and magnesium. Distal convoluted tubule was an important ion channel here. That'd be your sodium chloride channel. And it said calcium also can get reabsorbed here, but it has to kind of wait its turn. There's a lot of sodium, and sodium is a little bit more important, so it doesn't really get reabsorbed. But if you block this channel, then calcium can get reabsorbed. Our collecting duct was the main channels here. We had our channel that was similar to here, so we reabsorb sodium at the expense of hydrogen, and also at the expense of potassium. And we said aldosterone likes to work on this channel, kind of rev it up. And this channel was called the ENaC channel, ENaC. And then another thing we had was alpha intercalated cells that helped release acid and kind of work on our acid-base homeostasis. I think that does it. Not too bad, right? Just a few key facts that you need to know for each section. Let's talk about some pharmacology, okay? And we'll start with the PCT first. You have a drug called acetazolamide. That works on the PCT, and it works by blocking carbonic anhydrase. Carbonic anhydrase. And by blocking carbonic anhydrase, you kind of throw a wrench in the whole thing, right? You kind of throw a wrench in this whole system. So you can't reabsorb sodium, and kind of by nature, you can't also reabsorb that bicarb. And you pee that bicarb out. So right, decrease bicarb, you pee it out, you get this alkalotic urine. So why the heck would we ever want to do this? Well, when you pee out bicarb, you kind of reduce bicarb-rich fluids in your body. Some bicarb-rich fluids is the fluid in your eye, so it is great for glaucoma. Some bicarb-rich fluid is the fluid in your head, your CSF. And sometimes you can get too much CSF, you get intracranial pressure, raised intracranial pressure, and we don't want that. So it is great for raised ICP. So by getting rid of that bicarb-rich fluid, we kind of reduce that fluid. Yeah, kind of reduce that fluid, just kind of pee it out, nice and gentle. Some other times we want to do this is in altitude sickness. In altitude sickness, you breathe really fast, like you're in the Himalayas, and you breathe out all that carbon dioxide, you get alkalotic, respiratory alkalosis, right? So by giving this drug, we pee out alkalotic urine and you reduce that alkalosis. So I'll just write altitude sickness, altitude sickness. What are some side effects? You can imagine there can be too much of a good thing. You can pee out too much alkalotic urine. You become acidosis. That's not right. You become acidotic. So side effect, acidosis. That kind of makes sense. You also get something called Nh3 poisoning. You see, we get rid of NH3 by combining it with hydrogen to make NH4, and then we can just pee that out. If you throw a monkey wrench in this system, then you can't pump out hydrogen. And that means you can never combine with NH3, you never make NH4, you never pee it out. So you get NH3 toxicity. Okay? And I think that's all I want to say about acetazolamide. Another drug that works here is mannitol. Mannitol is basically an unabsorbable sugar. It's just a sugar, right? Sugar. So what does it do? Because it's not reabsorbable, it draws water towards it osmotically. And when it draws water towards it osmotically, you just get more fluid, more urine, you just pee that out. So I just write increase, what I want to write, increase urine. All right, I'll just write increase urine. Well, why do we want to do that? Well, sometimes you want to reduce the fluid in your body, or sometimes if you have some sort of drug overdose and you want to clear it faster, you can give mannitol. There's one major side effect that you must know. You'll give them the mannitol and it'll sit in your body and draw that fluid, all right? And it'll draw that fluid. And it takes some time before it gets to your kidneys. Yeah, it's not just instant, right? It takes some time before it gets to your kidneys. Here's the problem. In the time it takes to get to your kidneys, then all that fluid can get drawn out and go into your heart and exacerbate heart failure. It can go into your lungs, exacerbate pulmonary edema, okay? So it can exacerbate pulmonary edema and heart failure. So be very, very careful they don't have that. All right, because it takes some time. You gotta be wary of that. So that's your PCT. Let's look at your loops. We say your thin didn't really reabsorb salt, so there's nothing really to talk about there. Your thick loves reabsorb salt. It has this huge channel. And we can block this huge channel with loop diuretics. What a fitting name. One of them, and most famously, is furosemide. This blocks this channel. Easy as pie. Side effects. This channel is also found in the air, and if you block that channel, then you can have ototoxicity. When you block this channel, you can't reabsorb salt, you can't reabsorb water, so you pee out all that salt, pee out all that water. You can get really dry. That's kind of the point of it. Sometimes you can get too dry. And this can exacerbate gout, right? Because all that uric acid crystals that cause gout build up and cause gout. So, right, increase uric acid crystals. And then last but not least, you can lose calcium and magnesium. Calcium and magnesium? Why do you lose calcium and magnesium? Well, then we say your sodium, potassium, and chloride channel takes that all up, and your potassium just never gets the message. Leaks back, makes a positive lumen. That positive lumen kind of pushes calcium and magnesium out, right? Well, if you block that channel, you never have that push out, and calcium and magnesium never gets reabsorbed. So you can have low calcium and magnesium. Done? Good. There's one more drug that is often overlooked by its furosemide brother. Furosemide is just super popular, but there's one more drug that gets often overlooked, and this is ethacrynic acid. The only reason you would use this drug is because this drug is non-sulfur. It's a non-sulfur drug. A lot of people have sulfur allergies. Furosemide is a sulfur drug. So if they say a patient needs furosemide for whatever reason, maybe they have heart failure, but it has a sulfur allergy, what would you give in place of furosemide? That's the only time I've ever seen this asked, and I have seen it asked, then that's when you use this drug. Okay? Side effects. same thing. Ototoxicity, gout, increased uric acid, all that good stuff. So synthesize all of that into a step-like question. Can you do that? So a patient comes in, exacerbation of heart failure, fluid overloaded, you give them a drug, and then they start to develop tinnitus. They have a ringing in their ear. What did you give them? Furosemide. Or they now develop gout. What did you give them? Furosemide. So not only know your side effects, but be sure you're able to identify it in a step-like question. Moving on up to DCTs. We said your distal convoluted tubule had this nice sodium chloride channel. And if you block that, then calcium jumps in. Well, we can block this channel with thiazide diuretics. Thiazide diuretics. And when you block this channel, then you reabsorb calcium more. So you reabsorb calcium. Why will we ever use this? Well, we use the diuretic part of it for things like hypertension. Is a very common drug for hypertension, heart failure. But sometimes we want to really emphasize this reabsorption of calcium. So if a patient has hypertension and osteoporosis, why not just kill two birds with one stone? Why not just give them thiazides? That way you can get rid of the hypertension, you can also reabsorb some calcium. Probably help the osteoporosis. And in fact, I've had that question asked. Also, you can have calcium kidney stones where you have too much calcium in your urine. You get a kidney stone, we don't want that. So if we give this, we can reabsorb that calcium, kind of lower that amount of calcium that's found in your urine. So, all right. Osteoporosis, and kidney stones. Something you should know, thiazide diuretics can cause too much calcium. You get hypercalcemia. It can cause too much uric acid. Kind of like how we said furosemide can cause too much uric acid because you kind of lose all that liquid, you kind of dry yourself out. And it can cause hyperglycemia and hyperlipidemia. Why is that? It's not very clear why, but a lot of these drugs can reduce potassium in your body. Yeah, you get hypokalemic. This is kind of no exception. And if you remember from your GIT physio, this is your islet cell of your pancreas, and this islet cell of your pancreas releases insulin. And it can release anytime it's depolarized. Well, we don't want to release insulin willy-nilly, so we have a potassium channel that leaks potassium all the time and kind of hyperpolarizes the cell. Make sure it doesn't just depolarize willy-nilly. And when you're hypokalemic, you'll have less potassium outside, and your cells will sense this and send more out via the gradient. And that just further hyperpolarizes the cell, further stops insulin release. And if you don't have insulin, you can't reabsorb glucose, you can't reabsorb fat, so you get hyperglycemia, hyperlipidemia. Okay? Don't really think that's too important, but I have been asked questions about it. They'll talk about someone that's given thiazides and then might ask what's increased in their blood. Look for uric acid, calcium, glucose, and lipids. Okay. Last but not least, our collecting duct. Collecting duct, we said, had the Nh channel. This took in sodium and pumped out hydrogen and potassium. And we said aldosterone works on here. So the drugs that are going to work on your collecting duct will either work on Nh channels or work on aldosterone receptors. The things that work on Nh channels include drugs like triamterene, amiloride. Amiloride is probably the most well-known. And that just blocks Nh channels, Things that work on aldosterone all end in -one for whence its name. So spironolactone is a well-known one. Eplerenone is a little less known, but as long as you know it ends in -one, shouldn't be hard to pick it up on an answer choice, okay? So they all end in -one. And these are competitive antagonists. So you block sodium reabsorption, right? And if you block sodium reabsorption, then hydrogen doesn't get pumped out and potassium doesn't get pumped out. You keep those in your body. What do you think the side effects are going to be? You're going to get acidotic, you're going to get hyperkalemia. And sometimes we kind of want that. All these other diuretics made you get hypokalemic. So this allows you to retain some of that potassium. So these are sometimes called K sparing. Now there's some more side effects to this. Spironolactone in particular looks very similar to androgens, and it can go on the androgen receptors and kind of block them. So it can be anti-androgenic. So in men, what do you think you're going to see? You're going to see things like gynecomastia. You're going to see things like ED or impotence. Anytime a drug causes ED, you got to know it cold, because men don't take drugs that cause ED. They're just non-compliant, so you have to be very aware of these side effects. So can you think of a step-like question that synthesizes all this? Patient comes in, heart failure, you give them a drug, and then they start to develop gynecomastia, or they complain of erectile dysfunction. What drug did you give them? Or how does it work? Competitive antagonist at aldosterone receptor, blah, blah, blah. All right? So you should be able to crank all that out, make it into a step-like question, and if you can do that, then you're in good shape. That is Nephron Pharmacology. Hope that wasn't too bad. Thanks.